Sir, we are live. With all your permission, I'm starting this session.
Sure.
Good evening, everyone present here. I welcome all the participant doctors on today's session. Let's welcome today's speaker with great honor, none other than Dr. Parag Biniwale, sir. Sir has done MD, FICOG, FICMCH, and senior consultant in OPSI and Gynae, Pune, and PG teacher and unit head at Kamla Nehru Hospital, President Pune OPSI Gynae Society 2022 and 2023. And today, sir is going to speak on a topic, gestational diabetes mellitus. Let me tell you overview of the topic. That is gestational diabetes mellitus, that is GDM, is a form of diabetes that developed during pregnancy. It is characterized by elevated blood glucose level, which can pose health risks to both mother and the unborn baby. Proper management and monitoring of GDM are crucial to ensure a healthy pregnancy and reduce potential complication for both mother and child. To know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you. Good evening, all. I bring greetings from Pune, and it's indeed a pleasure to be talking to you all on a very important subject, that is hyperglycemia in pregnancy. At the outset, let me thank Team IJCP for inviting me here and giving me an opportunity to have a dialogue with you. So today we are going to discuss about hyperglycemia in pregnancy and newer insights. Let's first understand the magnitude of problem so that we know how important it is for all of us to understand that this is a situation which is here to stay and we have to put our best efforts to control it. So hyperglycemia is one of the most common medical conditions women encounter during pregnancy. More so in our country because we know that we are the diabetic capital of the world. So it is estimated that 1 in 6 live births occurs to women with some form of hyperglycemia, and 84% of it is due to gestational diabetes mellitus. Hyperglycemia or GDM is associated with maternal mortality, higher incidence of maternal morbidity, and higher incidences of perinatal and neonatal morbidity, and later long-term consequences, which are really going to be bothersome for the mother as well as the child. So when we talk about hyperglycemia in pregnancy, we have to understand that there are 127 million births take place during every year in the world, out of which it is estimated that 21 million women or 21 million pregnancies are complicated by hyperglycemia, but only 3 to 4% million are detected and treated, and very few of them receive postpartum follow-up and lifestyle advice, which is so important for her future life. So when we talk about hyperglycemia in pregnancy, we are probably dealing with a woman who is already diabetic, diagnosed before the onset of pregnancy, so it could be a type 1 or type 2, or a woman who becomes gestational diabetes mellitus, where the diagnosis is done for the first time during pregnancy. And this is not a problem related to only our country. World over, it is becoming a bigger and bigger challenge. Though world over, the incidence is seen to be anywhere between about 1.8 to 31%. In our country specifically, we are getting a lot more numbers, and it is estimated by FOXI and DIPSI that 33% women do develop diabetes in first trimester, about 40% of them in second trimester, and 28% in the third trimester. This is what the government feels, and 1/3 of pregnant women are found to be with hyperglycemia in pregnancy. This is what is postulated by FOXI and DIPSI. Why we are concerned about gestational diabetes mellitus or hyperglycemia in general is because of its impact during pregnancy. Women who have hyperglycemia, they are more prone in early pregnancy for spontaneous miscarriages. Later on in the pregnancy, they do develop preeclampsia, gestational hypertension. UTI or urinary tract infection is something which is so common in these women. And of course, they tend to have macrosomic babies and more chances of hydramnios. Delivery is not easy. More instances of preterm births, more requirement of instrumental delivery or cesarean section. Deliveries at times be traumatic because of a big baby. These women are more prone for postpartum hemorrhage, postpartum infections, and in general, it adds to maternal morbidity as well as mortality. The puerperum also is many a times stormy with infections and lactation failure. And very importantly, it is the long-term consequences which are often missed, which include weight retention, GDM in subsequent pregnancies, diabetes mellitus, and cardiovascular diseases. The neonate or the child is not spared. In utero, there's always a danger of congenital malformations, especially so if the sugars are not well controlled, more chances of stillbirths. These babies, when they are born, do develop a lot of issues like hypoglycemia, hyperbilirubinemia, polycythemia, etc. More chances of RDS, hypocalcemia, Erb's palsy because of traumatic delivery, and neonatal deaths are more commonly noted. And very importantly, this is the onset or the fetal onset of adult disease. So it is vitally important that we screen women in pregnancy. And when we think of screening Indian women, it has to be a universal screening. And it means that all women who are pregnant should be screened for hyperglycemia in pregnancy or gestational diabetes mellitus in particular. So when should this screening begin? The first screening has to be at the first booking visit. A repeat testing is important between 24 to 28 weeks. And DIPSI recommends if the first two tests are negative, a third screening test should be done between 32 and 34 weeks in order to make a correct diagnosis. So when we talk about universal testing, how do we do it? So in a minute, we will see how it is done, but then we interpret it as whether it is positive or negative. If it is negative, repeat testing at 24 to 28 weeks. If it is negative, again, manage her as normal antenatal case, and a third testing would be really important in order to detect the late cases which show hyperglycemia in pregnancy. So this is a single step described by DIPSI, that is Diabetes in Pregnancy Study Group of India, which involves using 75 grams of oral glucose and measuring blood sugar 2 hours after its ingestion. So the woman is asked to take 75 grams of glucose. So this is typically anhydrous glucose, which is added to about 300 ml of water. And this solution has to be consumed within a span of 5 to 10 minutes. Mind well, the fasting or non-fasting state of patient is not important at all. This test can be done at any time of the day. What is required is a plasma standardized glucometer should be used to evaluate blood sugars 2 hours after the oral glucose load. Now, if by chance the patient vomits within first 30 minutes of oral glucose intake, the test should be repeated. But if she has vomiting 30 minutes later, the test continues. How do we interpret this particular test? Now, when we estimate the plasma glucose level, we expect the level to be less than 120 milligrams percent. But if it is more than 120 or less than 139, we say that the woman is suffering from gestational glucose intolerance. The values between 140 and 199 denote that the woman is suffering from gestational diabetes mellitus. However, if the values are more than 200, we say that probably we are dealing with a woman who has overt diabetes, which was not diagnosed earlier, and is now diagnosed for the first time during pregnancy. So for these women, we really have to be vigilant because these are the ones who will develop hypertension at a later date. So retinopathy is pretty common. So a fundus examination is extremely important. And these women are more prone for nephropathies. So monitoring kidney function test is of great value. WHO in 2016 has given its own methodology how blood sugar testing should be done and how GDM is to be diagnosed. However, I personally believe that in Indian population, we should be doing a test which is time tested and researched in our own population, and that is the test by DIPSI. Coming to management, and we really have to be vigilant throughout the pregnancy, and the management has to be in accordance with available national resources and infrastructure. So when we think of management, there are three things that we have to keep in mind: that the woman should have a frequent follow-up. She should be under supervision of a GDM trained healthcare provider. It means that one who knows about GDM and is vigilant about GDM and its consequences. And third, and very important, is self-monitoring of blood glucose for all pregnant women with hyperglycemia in pregnancy. The care ideally should start in the preconceptional period. So whenever a woman comes to us for preconceptional counseling, we have to understand that we should be screening her for malnutrition. We should be screening her for anemia, overweight and obesity, hypertension, diabetes, and thyroid functions. So all these factors have to be assessed. Once we look at these values, appropriate advice has to be given. And then we usually start supplements of folic acid and B12 for these women and discuss with them lifestyle modification and how important it is to follow it up, especially when they are planning to conceive. So now let's go back to our GDM, and now the GDM is diagnosed. What next? So it is important that we advise medical nutrition therapy to our patient, and she should undertake a good amount of physical exercise and at least 30 minutes a day. So if you do not have time, ask a nutritionist to talk to the patient, give her a good diet chart, which is low in carbs, and a physiotherapist can be of great help in charting out the exercise pattern for this particular patient. So once this is done, we call the patient after 2 weeks, and then we do a 2-hour postprandial blood sugar level. Mind well, it is 2 hours postprandial. Now, if the value of postprandial blood sugar is less than 120 milligrams percent, we continue medical nutrition therapy and ask her to continue the physical exercise which she has started. And this has to be monitored frequently as per the physician's recommendation. Now, if after 2 weeks, the 2-hour postprandial blood sugar level is more than 120 milligrams percent, and this is what the government of India says, some physicians believe that the value should be more than 140. We should start some kind of therapy in order to control the hyperglycemia, and the therapy may include oral antidiabetics. The commonest one being prescribed is metformin or insulin, as per the need of the patient or as per the physician's choice. We, of course, continue monitoring fasting blood sugar and 2-hour postprandial blood sugar every 3rd day, or more frequently, especially if we have started insulin for the patient, where we expect her to monitor the sugar levels every day. So when we talk about medical management, it's always a tussle between insulin and oral hypoglycemics. Now, both these are accepted medical managements for pregnant women with gestational diabetes mellitus who are not controlled with medical nutrition therapy. In general, insulin has always been the first drug of choice, and metformin can be considered after 20 weeks of gestation for medical management of gestational diabetes mellitus. Now, insulin can be started at any time if the medical nutrition therapy fails. And we also have to understand that hypoglycemia and weight gain with metformin are less noted in compared to insulin. And if insulin is required in high doses, we may have to add metformin at a later date. So when we talk about oral hypoglycemic agents, of course, there are acarbose and glycerides which can be used for management of hyperglycemia in pregnancy. But what is found out is metformin does have an impact on the fasting hyperglycemia. It is safe. Gastrointestinal intolerability, there could be some issue. Some women may complain of loose motions. It does have an impact on the insulin resistance. So women who are known case of polycystic ovaries and who conceive and are diagnosed to be hyperglycemic will be immensely benefited with metformin. And of course, it does not have any impact on the weight. So it is supposed to be weight neutral, or some women may lose a little amount of weight. And it can be administered once or thrice a day, depending on the need and depending on the choice of the physician. But we have to also remember that metformin is something which has its own share of issues. It was found out that metformin exposed children had higher BMIs at the age of 4, and they also had increased prevalence of being overweight or obese at the age of 4 years or so. Coming to insulin therapy, and I've borrowed this chart from the Government of India guidelines on hyperglycemia in pregnancy, and it explains beautifully how we should be monitoring the blood sugars, how insulin has to be administered, and we can blindly follow this particular chart to make sure that we control blood sugar levels properly. So when we compare metformin vis-a-vis insulin, there are so many trials which talk about it. Now, what is seen was there is a comparable clinical equivalency of metformin compared to insulin. Macrosomia was significantly lesser in women who were on metformin rather than insulin. And the chances of neonatal hypoglycemia were significantly lesser in metformin group as compared to insulin group. So we always talk about safety of metformin, and there is no clear-cut evidence of any adverse outcomes related to the use of metformin for the treatment of hyperglycemia in pregnancy. However, most of the guidelines recommend metformin after 20 weeks of pregnancy for use in women who have hyperglycemia in pregnancy. There are some absolute indications for insulin in pregnancy, and this is something which we all should remember. So if there are significantly high diabetes-related morbidities, which includes high HbA1c or ketonuria, significant medical morbidities, which would include associated renal or hepatic dysfunction, significant obstetric morbidity, which includes macrosomia or fetal growth restriction, hydramnios, or expected deterioration of glycemic control, and of course, antenatal corticosteroid therapy. What is important is monitoring of these women during pregnancy. So when they come in the first trimester, and suppose you diagnose her to be hyperglycemic in the first trimester, of course, the clinical examination is important. A dating scan is done along with nuclear translucency and biochemical screening. We also look at the uterine arteries because that will give us a prediction about preeclampsia. And we also look at the other vessels so that we come to know about the possibility of fetal growth restriction. The clinical examinations continues periodically even in the second trimester, and a good anomaly scan is important at around 19 weeks of pregnancy. If a dual marker is not done, quadruple marker is recommended, triple is now out. Amniotic fluid index has to be looked at because we are dealing with a woman who has hyperglycemia, and these are the women who are more prone for developing hydramnios. A fetal echocardiography between 22 to 24 weeks is extremely important. In the third trimester, we continue monitoring the patient clinically. So here, important parameters that we should be looking at is the fundal height and abdominal girth that will tell us clinically how the baby is growing. And growth scans are recommended between at 28, 32, and 36 weeks. And of course, color Doppler as and when indicated. So we should also look at the amniotic fluid index, and a non-stress test is to be started at around 32 weeks, especially if the woman is on insulin. Ultrasound assessment has to be done by an expert sonologist or a fetal medicine expert. Apart from baseline ultrasound, it is important to rule out any major malformations between 18 and 22 weeks, along with fetal echocardiography. And later on, in the second and third trimester, we continue monitoring these women for the growth and light curve volume. Monitoring of sugar is extremely important, and all women who are newly diagnosed as hyperglycemia in pregnancy or gestational diabetes should initially be provided with education, preferably in a group multidisciplinary session. Now, this education usually covers an importance of GDM, its implications and need for management, education in self-blood glucose monitoring, initial dietary and exercise advice, and long-term health implication. So in general, all women with GDM are asked to get a glucose meter and a diary in which their blood glucose levels are to be monitored very strictly, and they should be given written information about gestational diabetes mellitus and diet that they need to follow. So when we think of antepartum monitoring, home sugar monitoring has its own important place. Antenatal visits are more frequent. Women are asked to do a strict daily fetal movement count. Most of the guidelines talk about a CTG from 38 weeks onwards, but it may be required earlier if there are other risk factors, including abnormal fetal growth and hypertensive disorders of pregnancy, which are so commonly associated with hyperglycemia. This is one important chart we must keep in mind, and this has to be pasted in our OPD or in the labor room so that we know how what action has to be taken and how urgently. Coming to the role of steroids, routine administration not required. Only in women who show signs of preterm labor, we should offer them dexamethasone or betamethasone in the dose of 6 milligrams 12 hourly 4 doses, or 12 milligrams 12 hourly 2 doses. Close maternal glycemic surveillance is a must, so it may be a good idea for us to admit the woman and monitor her sugars closely. If she's already on insulin, we may have to increase the dose of insulin, especially when we administer steroids. Care and in labor and delivery is extremely important, and FIGO recommends that we should do a proper assessment at around 38 to 39 weeks. If the expected birth weight is more than 4 kg, one may offer elective cesarean delivery, looking at all the circumstances. If the weight is less than 3,800 grams, or if we are dealing with an appropriate for gestational age patient, the next thing which we should look at is about the glycemic control, about the compliance of the patient, whether there's a history of previous stillbirth or vascular diseases. If none of these factors are present, one may continue monitoring this patient and try and deliver her between 40 and 41 weeks. But if there are issues related to the control or compliance, or if we are dealing with a woman who has microsomic baby, we need to think of inducing labor at the appropriate time. So the $1 million question is when to deliver. And if you look at various guidelines, they will talk differently. What most of us are following is the RCOG guidelines. So pregnant women with type 2 diabetes mellitus, induction of labor vis-a-vis C-section between 37 to 38 plus 6 weeks. If there are any metabolic or other maternal or fetal complications, then we can think of elective birth even before 37 weeks. And diabetes should not be considered as a contraindication to attempting vaginal birth even after previous cesarean section. Now, the SOGC says, the Canadian Society says that pregnant women with GDM should be offered induction between 38 to 40 weeks of gestation, depending on their glycemic control and other comorbidity factors, while the WHO recommends that if GDM is the only risk factor, induction of labor before 41 weeks is not recommended, and induction of labor for suspected fetal microsomia is not recommended. So the question always remains when to deliver, and the ACOG says that well-controlled GDM only on exercise and diet, one can continue till about 39 to 40 weeks. GDM well-controlled on medication anytime after 39 weeks, and GDM when poorly controlled, we can think of delivering them as late preterm or even early term, and this has to be individualized. So there is a lot of confusion when we talk about delivering a patient who has hyperglycemia in pregnancy or gestational diabetes mellitus. So there are some studies which talk about induction of labor before 40 weeks, and what they have quoted is that it is associated with lesser chance of cesarean section in women who have hyperglycemia in pregnancy. Now, when these patients are in labor, it is important that we ensure that she delivers in an institute. Presence of expert obstetrician is very important, and close electronic monitoring is what is recommended. Now, if she has hyperglycemia in pregnancy, which is controlled on diet or spontaneous labor, admission CTG is performed, and we can do continuous fetal monitoring apart from sugar monitoring every 2 hours. Women who are already on insulin or oral antidiabetics, they have to be monitored very, very closely, and we may have to administer IV fluids as per the blood sugar levels. Coming to the second and third stage of labor, here we should make sure that we do a controlled ARM. We must anticipate a shoulder dystocia or an assisted vaginal birth. Neonatologist or a person who's trained to resuscitate the neonate has to be present. We should do close monitoring in the second stage, watch for fetal stress, because here second stage stillbirth is a known entity, and we really have to be very, very careful when we are attempting a vaginal birth in these women. And of course, vaginal delivery should be preferred, and LSCS is to be done only for obstetric indications only. The third stage has to be managed actively, because these are the women who are more prone for traumatic or atonic postpartum hemorrhage. The care continues in the postpartum period as well, because these are the women who are likely to get infected even during the puerperium. They do require a lot of support for breastfeeding. We should be giving them proper advice on pregnancy spacing. So contraceptive counseling is extremely important. Retesting of all women with hyperglycemia in pregnancy should be done between 6 to 12 weeks postpartum, and there has to be a guidance to the patient as to how the glucose, future blood glucose tests are to be done. So once we repeat a OGTT between 4 to 12 postpartum weeks, if the levels are normal, we have to assess the glycemic status every 1 to 3 years, make sure that she loses her weight, which she has put on during pregnancy, and physical activity counseling has to be followed as per needed. If the values are more, fasting value is more than 125 and a 2-hour post glucose more than 199, we know that she is now over diabetes and needs care by a diabetologist. And if the values are in between, we have to consider referral for management, and medical nutrition therapy is extremely important in these women. Coming to the contraceptive choices, barriers can be used. Women can opt for long-acting reversible contraceptives. Progesterone-only pills or DMPA can be offered to these women during the postpartum period. However, women who have microvascular diseases, we will certainly not ask them to use COCs or implants or rings. Recurrent gestational diabetes, we have to understand that women who develop gestational diabetes there's a 40% chance that she may develop gestational diabetes again. So inter-pregnancy counseling is extremely important. So to conclude, universal testing of all pregnant women is extremely important for diagnosis of gestational diabetes mellitus. Testing is recommended twice in pregnancy, at the first antenatal visit and then at between 24 to 28 weeks. DIPSI recommends additional screening at 34 weeks. Single step 75-gram 2-hour OGTT test is the preferred method, and women who test positive with a plasma glucose of more than 140 should be started on medical nutrition therapy for 2 weeks, and then if the postprandial blood sugar levels are more than 120, we have to switch on to the oral hypoglycemics or insulin as per needed. Early delivery with administration of prophylactic corticosteroid therapy for lung maturity to be planned only if uncontrolled blood sugars are there or if there's any other obstetric indication. Vaginal delivery is preferred. Neonatal monitoring for hypoglycemia and other complications is extremely important, and postpartum evaluation of glycemic status by a 75-gram glucose OGTT at 6 weeks after delivery is an important issue. So thank you very much. And once again, I would like to thank Team IJCP for having me here for a discussion on a very pertinent topic of hyperglycemia in pregnancy.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participant doctors on their practice also. Sir, we can see, sir, we have received some question from the participant. And if you allow, can I take this question with all your permission?
Sure.
First question is from Dr. Himanshu. He is asking, how do the ACOG and ADA guidelines for the diagnosis of gestational diabetes mellitus differ?
Honestly, when we talk about gestational diabetes, I think our people are much more experienced because, as I mentioned earlier, we do have a lot of diabetics, or India is the diabetic capital. So we really don't refer to the ACOG or any other guidelines. We always stick to the DIPSI guidelines, which are so relevant as far as our country is concerned.
Thank you so much, sir. I hope that Dr. Himanshu has received his answer. Moving forward, I can see another question from Dr. Sadhana Agarwal. She is asking, practically how many times a lady should measure her blood glucose level when on metformin or insulin?
Okay. Now, if the woman is on insulin, daily monitoring is extremely important. So we usually ask them, of course, this is we always take a physician or a diabetologist on board. And what generally they recommend is when the patient is on insulin, we have to do a fasting post lunch and post dinner sugars every day. If she's on metformin, we usually ask them to do it twice or thrice a week. Maybe twice a week is more commonly done. Fasting and postprandial.
Okay, sir. Thank you so much, sir, for answering this question. We can see there are a couple of questions from the participant in, and Dr. Subramaniam is asking how are the result of a 75-gram glucola, that is OTT reported, OGTT reported.
Okay. Now, if you refer back to the slide, if the value is less than 120, we say that it is normal. If the value is between 120 and 139, it is reported as gestational glucose intolerance. The value between 140 and 199 is reported as gestational diabetes mellitus. And if the value of more than 200 is to be reported as overt diabetes mellitus.
Thank you so much, sir, for explaining it really well. We will be taking last question for today's session, which is from Dr. Kumar. He is asking what is included in the patient preparation for a gestational diabetes mellitus screening test.
Okay, now screening test here we have to understand that it can be done on an OPD basis. So let's imagine that a patient has come to you for a regular checkup. So you give her a glass of water, 300 ml of water, add 75 grams of anhydrous glucose. It is commercially available. Stir it well. Ask her to finish it in 5 to 10 minutes. And for next 2 hours, she's not supposed to do any kind of exertion. So we ask her to sit or rest wherever she is. And then she's not supposed to eat anything. She's not supposed to take any medication during this. And then we collect blood. Even a glucometer is fine, or a plasma glucose estimation has to be done. So this has to be done exactly 2 hours after she finishes consuming glucose.
Okay, thank you so much, sir, for answering all the questions. I hope that all the doubts of the related to this topic of the participant has been clear. As I can see, there is no more such questions from their end. Sir, as there is no more questions, sir, with all your permission, shall we conclude this session?
Yeah, sure. Thank you very much.
Thank you so much, sir, once again for your valuable time and making the doctors as well as general public aware about this topic, sir. And hope to see you again with a different topic in coming times. Take care of yourself, sir.
Yeah,
Happy
thank you.
Independence Day in advance,
Yeah,
sir.
happy
Take care.
Independence Day. Bye-bye.